Good afternoon, everyone. Sorry for the delay. Stuck with some patient. Now, today we discuss with approach of neonate with cyanosis and how the cardiologist point of the view. This is the first X-ray you see on the screen that shows a big heart. Good afternoon, everyone. Sorry for the delay. Stuck with some patient. Now, today we discuss with approach of neonate with cyanosis and how the cardiologist point of the view. This is the first X-ray you see on the screen that shows a big heart. Sorry for the delay. Today we discuss the approach of cyanosis and how the no. But it's good afternoon, everyone. Sorry for the delay. Today we discuss the approach of the neonate with cyanosis. Now this is the and how the cardiologist and will help and how the simple clues by the help of X-ray, ECG and the clinical feature were able to make out the plausible diagnosis and that will help you in your treatment. So first X-ray on the screen, you can see there's a huge cardiomegaly referred to us for cyanosis. The only two things whenever you are seeing the cyanosis, first you have to rule out anything is a cardiac or non-cardiac. So, and after that cardiac, you have to see only two things, whether it's a cardiomegaly, non-cardiomegaly, oligemia or hyperemia. So with that, I'll consider. See, there is something which is known as the reduced hemoglobin. So cyanosis will appear. Cyanosis means blue. So when the cyanosis appear, when the venules, normally in our venule there are 2 gram reduced hemoglobin is present, and for cyanosis to appear you need 5 gram of reduced hemoglobin, 5 gram percent of reduced hemoglobin. So that means we need 3 more gram percent of hemoglobin for cyanosis. So this needs, when there is a cyanosis, right to left shunt, polycythemia or high hemoglobin, that 3 gram will be easily available. That's why the cyanosis is more apparent in presence of polycythemia. So this is the example. Suppose to get the 3 gram of anemia in presence of 6 gram, it will be very difficult. So that's why the cyanosis will appear very late, or even when the saturation drop to 45-50%. When in the polycythemia with the hemoglobin of 20 gram, it's easy to get 3 gram percent of that reduced hemoglobin, so that in 80-85% is reduced normal, and the 15% of the hemoglobin in general, 15% of your the hemoglobin, if you consider 5 gram, the 10, if you consider 20-30% of the reduced hemoglobin is required from the hemoglobin. So that is the general concept. You can see severe anemia. This is anemia, normal, polycythemia, total hemoglobin, how much is there and how much is the reduced. To get 3 that much, it is very easy to get in a polycythemia present. That's why in presence of polycythemia, you will get the cyanosis appear early, while in anemia, the cyanosis will be masked. Even in presence of severe cyanosis, we will not able to see the cyanosis. So there are some points. This is a very common question, and this is very important thing. What are the cyanotic points? Cyanotic points are the points or the criteria where the cyanosis appears. So in pulse oximeter, whenever there is a less than 92% is there, that means the cyanosis is present. In clinical examination, between 85-88% in presence of normal hemoglobin, you may able to see the cyanosis clinically. As I told, in lab, reduced hemoglobin whenever 5 gram percent is there, methemoglobin when 2 gram percent is there, and self-methemoglobin whenever more than 0.5 gram percent. These are the cyanotic point. At that point, the cyanosis is appear, we are able to detect the cyanosis. So to go with any cyanosis in a neonate, we have to see the cause of cyanosis. So you can see there is a hypoventilation, that means the lung problem or central problem, or when the baby is depressed, and VQ mismatch, when the lung oxygenation and the peripheral is a problem. Diffusion, when the lung is not able to deliver the oxygen, like in ARDS, right to left shunt, that is seen in at the lung level as well as at the heart level. Inadequate adequate transport, that means the hemoglobin which is carrying the oxygen will have problem. So we can see hypoventilation with the central cause, lung disorder, cyanotic CHG are the central causes, hemoglobinopathy are the central causes, and the peripheral causes are the different. So you have to differentiate whether it's the peripheral cause or it's a central cause. So peripheral, it's a very simple blue, green finger, toes, palm that are cold to touch, and color returns after the body part is warm. That is the typical of peripheral cyanosis. It is more obvious in presence of polycythemia, cold, and in the shock when there's a perfusion is very poor, and that's why the extremities are cold and clammy, and you have to understand with the other clinical features. So this is a typical of peripheral cyanosis. So in general, peripheral cyanosis is sometimes a very common in the 24 hours because there is a right to end because of the hypothermia and the vasoconstriction in the periphery. If cyanosis persists for more than 24 hours and peripheral cyanosis is there, then it's a very serious diagnosis. So you have to see of septic shock, cardiogenic shock, or hypovolumic environmental exposure where the temperature is not maintained. So this you have to remember this. So in general, again, central cause, that means central related to the brain, heart, and lung. So that means decreased arterial saturation, high altitude, alveolar anatomical shunt, hemoglobinopathies, and then peripheral cyanosis. I already told, arterial and venous obstruction. So this with that will I show you one of the very good example how to differentiate peripheral and central. The 2 days old referred for management of suspected coact in view of distress and differential BP. There is a radiofemoral delay. Started on prostaglandin infusion, but lower limb perfusion in spite of prostaglandin infusion not improved. When we checked deco, because initially thought of coarctation started on prostaglandin, but when we did deco, there is no coarctation and there is a large PDA. But the upper limb pulses are there, lower limb pulses are in absence of aortic obstruction and in absence of coarctation. What may be the possibility? So sometimes very distal aortic obstruction will be there, like in the abdominal aorta or at the bifurcation of the aorta. So when we saw there is a large PDA in spite of there are poor pulses and the peripheral cyanosis not improving after 24 to 48 hours in presence of normal function, we thought there is a descending aorta block. So we suspected, and when we did the Doppler and with the radiology, we found out there is a complete thrombotic occlusion of the aorta and bifurcation and the femoral with thrombus. So we treated with heparin, urokinase, low molecular weight for 14 days, and the patient improved. One of the very important and very less used modality is pulse oximeter. You have to see, when you see the plethysmography, this is known as the plethysmography trace. When you see the peripheral trace or aortic trace, that is known as the pulse, and that is the plethysmography. So when you see the first is after 14 days, that means still there is a dampening. The pulse pressure is less, that means still there is thrombotic occlusion is present. And after 20 days of treatment, you can see the improvement in the pulse volume. So whenever the pulse volume you are unable to see in presence of the warm peripheries, or you are unable to see even in the presence of cold periphery, you not see, then it's a, you have to correlate with the clinical feature to get the diagnosis of that. So here, see, this is after the 3 weeks of the treatment, you can see the baby become completely pink. So now if you see the pulse oximetry, that is very important. Whenever you see, it has to be like this. But when it's a low amplitude, then you have to think of low cardiac output, thrombotic occlusion, obstruction, other things. So that is a very important tool we should use in our clinical practice more often. So now again, this is the example of peripheral cyanosis in presence of thrombotic occlusion of the periphery. Now there's a 10 days old, poor feeding, deeply cyanosed, saturation is 85%, referred for cardiac evaluation because the baby is looking very dull. This is the we did the ABG because of the sinus. We found out the saturation is 92%, but you can see the blood. Blood is still deep cyanosis, so there the saturation is 92%, but deep cyanosis. So whenever there is a mismatch, when the deep cyanosis is there and the blood, you can see there is a very typical of methemoglobinemia. But when in neonate, whenever you have low saturation, but the cyanosis is severe, but the saturation is almost coming 85, 80, 90, 91%, because it has got the high affinity. So it will not show on the pulse oximeter, because pulse oximeter may not able to detect the methemoglobinemia sulfoximeter, sulfmethemoglobinemia. That's why it will show the 92% saturation. But if you see the blood, you will see it's a more red because of the affinity, high affinity, and then it's a deep cyanosis, but saturation is normal. PO2s are over the normal side. So this is a typical of methemoglobinemia. So this child found to have methemoglobinemia, and when how to differentiate methemoglobinemia in an adult? When in adult methemoglobinemia, because the PO2 is maintained, so there won't be any hypoxia per se in spite of severe cyanosis. There's a mismatch of the cyanosis and hypoxia. So that is, you will not find clubbing in methemoglobinemia. That is a very clinical important differential point between methemoglobinemia and cyanosis. So this is found out. So once we already discussed this. So when you find out cyanosis, you have to see the history of PROM, C-section, preterm, RDS, meconium, sedative, depression, central cause, fever, which is causing sepsis, pneumonia, and drug history is also very important, because in some of the like Ebstein, some antidepressants that will cause Ebstein causing severe cyanosis. Maternal diabetes more prone for RVH, LVH, which is called more right to left shunting, and then it is more common presence of TGA, and the connective tissue disorder, which is causing the high cardiomyopathy and then causing. the cyanosis in view of the dysfunction. So VQ mismatch whenever is there, this is the one form of the cyanosis, TTPN, RDS, pneumonia, or extrinsic compression like pneumothorax or effusion. This is one of the very this neonate with prolonged stage of labor require resuscitation having severe cyanosis not improving, but we are unable to get, but at that point we are not having transillumination. Otherwise, whenever any neonate not improved, as per you to do the transillumination after resuscitation, found to have large tension pneumothorax, and that is causing the cyanosis, and this cyanosis improved after posting the ICD. So in the same way, 14 days old veter abnormality with having the VSD with PS with tracheoesophageal fistula underwent repair and develop the tension pneumothorax, develop the severe cyanosis after, even after the ICD is there because ICD was blocked. So whenever anything on ventilator, you know, the displacement of the tube, obstruction, pneumothorax or equipment failure, and whenever any substrate is like that, you have to think of, when the resuscitation happens, to think of the pneumothorax or the lung cause as a cause for cyanosis. Here there is a 20 days old, you can see the right lung is totally white out and the heart is shifted toward, that means right lung hypoplasia is there. So this is diagnosed to large scimitar syndrome and large collateral causing the CCF. So we close the collateral and causing the improvement in the symptom, but the scimitar is one of the cause for the severe cyanosis and severe PH at birth. In the same way, one of the form is right lung agenesis. You can see the right lung is totally shifted and white out and heart is shifted toward that side. So that is causing the right lung agenesis and that is causing the cyanosis. This is one of the very common examples. CDH is causing the severe PH and PPH and causing the cyanosis. So once you see, these are all the respiratory cause, CNS cause, hemoglobin cause, and the vascular cause. And this is the typical of your RDS, HMD when in a preterm. But in the same way, whenever the term is having, and when your neonate is not fitting into the RDS, what you have to think. So this is one of the example, 4 hours old, 32 weeks, 1.4 kg, given surfactant, no improvement, X-ray worsened and ventilator setting increases, started on HM4 and then cardiac review was taken. This is the totally white out RDS. So whenever RDS like which is not fitting, to you have to think of your pulmonary venous cause like pulmonary obstruction, like a TAPVC, obstructed TAP. That is one of the most common, hypoplastic left heart syndrome or cort retractor. So this found to have the severely obstructed supracardiac TAPVC. So how to diagnose? Here we have to take the help of the echo and the pediatric cardiologist. So this is the normal LA, which is the rough and the pulmonary vein you are seeing. And but when the LA is bald, it is the typical of the pulmonary venous confluence is not there. It is going somewhere, and in that 100% PFO should be shunting right to left. So this is the typical of TAPVC. So this is the patient with a large confluence is there behind and there is no comet in this. So this we found out to this patient severe vertical vein obstruction, and because we able to diagnose, we did the transumbilical vertical vein stenting and we salvaged the baby, and after 10 to 15 days baby underwent the TAPVC repair and now doing very fine. So learning point, any term RDS, reticular pattern, ground glass pattern, poor response to surfactant, and which is often missed on fetal echo. So don't rely 100% on the echo report. High suspicion is required to diagnose the TAPVC or pulmonary venous obstructive diseases. So the other again, two patients with the same 6-year-old distress, 3 days old with distress, reticular pattern which is known as, in two differential diagnosis, obstructed TAPVC and the Gupri streptococcus infection and the HMD. So there's a very common thing. This reticular pattern is very common in the neonate because of the it is called interstitial edema because of the poor lymphatic supply. In adult, because of the good lymphatic supply, that interstitial edema will be dissipated by the lymphatics into the venous side. But in neonate, lymphatics are poorly developed. That's why develop the interstitial edema that is causing the reticular pattern. So cyanosis, if it's a peripheral, you will see on the tongue and it will be pink. Tongue will be pink and the central lips, tongue blue, PO2 saturation low. Cardiac usually worsens with crying because of the more demand. But with the pulmonary, there may or may not improve with the crying. But sometimes the traditional teaching, when you take a deep breath in crying, it will improve. But when it's having distress, when distress, that maybe the pulmonary and all, then you have to see how to differentiate between pulmonary and that. So that how we'll differentiate here. So neonate with cyanosis, acrocyanosis, central cyanosis, clinical evaluation you have to do. If you have the tachypnea, distress, improvement on oxygen, and abnormal respiratory examination, increased PCO2, lung collapse, consolidation, pneumothorax, anything is a respiratory physiology. When there's a differential cyanosis, it may be cardiac or it may not be cardiac, just like a PPHN, but cyanosis will be more severe, no change with the oxygen or minimal change, abnormal cardiac examination, normal PCO2, but the excess or lung parenchyma or cardiomegaly, plethora, or elegema or reticular pattern with abnormal ECG. So when this is there, it is more suggestive of the cyanosis. So this is a very simple test, hyperoxia test, that is required to differentiate cyanotic heart disease from the respiratory cause. Hyperoxia test, you give 100% oxygen for 10 to 15 minutes by CPAP, O2 tube, anything. When PO2 increases to 150 or there is a rise from 80, suppose 60 PO2, then it becomes 80 or 90, that is more than 20 mm rise, and the saturation becomes 100% or rise is more than 10%. From 80 went to 90, 92%, that is more commonly pulmonary cause. But when PO2 is less than 150 or rise is less than 20%, saturation 90, it may be still PPHN or cyanotic CHD. Again, you do the hyperventilation with face and mask ventilation in the 100% with the high rate. So with PPHN, with the high rate like HFO, more than 100, 120 per minute, the PO2 will improve. So that is typical of PPHN, but the cardiac or cyanotic patient will not improve. So this is the interpretation of the hyperoxia test. So this is day one of life. You will often see PDA with a hypertensive, PDA with the bidirectional, this is a tripod sign. So for differential cyanosis, uniform cyanosis present in all, upper, lower, it's same. Differential means there is a either there is a cyanosis up or lower is normal, or lower is cyanosis and upper is normal. This is only for that two things are compulsory. Either the presence of PDA should be compulsory, or then either there is a PPHN or the coarctation with PDA. So these are the different aorta to pulmonary direction of the shunt. Normally is from the left to right aorta. That's why baby is pink. Second is pulmonary artery to aorta. In normal cardiac examination, it is related to PPHN, but in abnormal cardiac connection, it may related to the any other thing which is causing severe PH like PPHN. And pulmonary artery to aorta flow is there, but it's a reverse differential cyanosis because upper is more sinus than lower, that is the TGA. And when there is a TGA without pulmonary hypertension, you will still get left to right shunt, but the overall cyanosis will be there in the TGA. So these are the four conditions where the differential cyanosis will be there. So in general, if you remember peripheral cyanosis, and there is a very simple mnemonic: cold palm. So cold obstruction, like I showed, LVF and shock or decreased cardiac output, that will cause peripheral cyanosis. Central cyanosis, polycythemia, P, altitude, lung diseases, meth or sulfur, and shunt at the cardiac or the lung level. So these are the differential. So now if we come to the cardiac now, what are the three cardinal presentation of the cardiac disorder? It will cause blue, gray or pink. So whenever cyanosis is there, that means the flow to the lung is decreased, and that is the one condition that is known as the pulmonary atresia, which is known as the transposition physiology, which is known as the DTG. Second is when there is a distinct systemic perfusion, that means critical aortic stenosis, which present as a severe peripheral shock and may present as cyanosis, that may be the critical aortic stenosis. Third thing is tachypnea, which is not related to PDA, that's why we not discuss it. So we have described the two category of the cyanosis, like cyanosis with increased flow, cyanosis with decreased flow, and cyanosis with decreased systemic perfusion. So there are the three categories we have to differentiate with the cyanotic CHD. So if you see any cyanosis as per age, the age on admission on 0 to 6 days, the most common cyanotic heart disease in neonate is TTG. After that is HLHS, and third is tetralogy of Fallot with severe obstruction of pulmonary atresia. So this you have to remember. And other less common are tricuspid atresia and single ventricle. So if you see the duct-dependent lesion, that means the PDA is essential for survival. That pulmonary lesion, like which is present as a cyanosis, tachypnea, acidosis without any retractions. Only tachypnea will be there because there is no lung congestion, lung flow is less. So these are the typical of pulmonary atresia, critical PH, severe TOP. In the systemic, interrupted aorta, coarctation, severe acidosis, there will be severe acidosis, baby will be sick, and the baby pallor, shock. So in that you need these are known as the duct-dependent circulation. One is pulmonary and the second is systemic. So you need prostaglandin lesion. Other is that. So now if you see, there are five, like in that neonatal cyanosis day one. First is total anomalous, TAPVC, tricuspid, TGA, truncus. These are the famous five. Apart from the single ventricle and acardia are the other causes of the cyanosis. So now we come to the core thing, the cyanotic CHD. If you see increased pulmonary blood flow, decreased pulmonary blood flow, these are the dependent on the PDA, like tetralogy of Fallot, which severe without PDA it may not survive. Tricuspid atresia, Ebstein's anomaly, pulmonary atresia, these are the decreased pulmonary blood flow. Increased pulmonary blood flow, TGA, truncus, single ventricle, TAPVC, and the hypoplastic left heart syndrome. So what is the basic differentiation? So if you see anywhere decreased lung flow means there are more cyanotic, more tachypnea, no retraction. That's a quiet tachypnea, but there will be oligemia on the X-ray. On the contrary, increased flow, there will be more retraction, there will be more distress, increased rate as well as the work of the breathing, and there will be X-ray, there will be plethora or reticular pattern. So if you see clinically, you have to see only two things: cyanosis with tachypnea, no work of breathing increase, only rate increase, and the depth increase, the work of breathing not increase. That is typical of the decreased flow. And when there is increased flow, there is work of breathing, retraction, and nasal flaring, all will be there. And then you have to see the cardiac size on the X-ray. So when you see the cardiac size on the X-ray, increased cardiac size, there are only 3 or 4 diagnoses: tricuspid atresia, pulmonary atresia without VSD, severe PS with causing severe TR, Ebstein's anomaly, and the transient TR of the newborn. And in normal cardiac, TOF, DO, RVC, all PS physiology, like TOF physiology come in a normal cardiac size, because cardiac increase size is abnormal for the TOF physiology. This is not decreased flow. Increased flow, when you see complete admixture like TAPVC common, will show the other, and then incomplete there is a TJ. These are the 4 or 5 examples of the increased flow. So now only there are 2-3 cases we have to assess whether it's a whether cyanosis is there, cardiomegaly is there, or oligemia is there. That's all. Only 3 things we have to say. 3 days old, born to GDM mother, presented with cyanosis and tachypnea, but no distress. Metabolic acidosis present, room air saturation is 55. What I told, there is no distress. That means lungs are not involved. That means it's a more oligemia rather than the increased flow. Okay, so what happened? So if you see, this is a normal vascularity, no cardiomegaly on day 1 of life, but it increased to increased vascularity, cardiomegaly in day 4 of the life. So if you see, there's a cardiac size is increased, yes, and the flow is also increased. Now it's seen as a plethora, and that is why this is the cyanosis, cardiac size increase, and the increased flow. So that is a typical of the. And once we found that there's an admixture increased flow. That means there's an admixture lesion. So 3 days old, weight 3.8, saturation symptomatic with dyspnea and cyanosis. You can see aorta, and this is the echo that shows aorta and PA. Normally, what happened? The aorta and PA you will not able to see in the one plane. This is a normal heart. You can see the aorta will see, and once you go more anterior, you can able to see the PA, which we have crossed each other. But once you see both vessels in the same parasternal view or in the 5-chamber view, aorta and PA, that is the typical of the transit, that is the parallel circulation. So this found out to be the TGA, and this is the typical what we showed. You can see that X-ray. This is a typical agon. There is a narrow infundibulum, narrow pedicle of the heart. That means base of the heart is small. So this is a typical agon sign and agon string appearance, which is typically seen in the TGA physiology. But TGA, you have to remember, they may present with acidosis, they may present with tachypnea, they can present with severe cyanosis. Any cyanotic heart disease in birth, first diagnosis is the TGA. That is because that is the most common. So for some patient, we need to do the bath, and then we have to send for the surgery. This is second case, 2 days old, presented with distress. Distress means having tachypnea, work of breathing is high, in cyanosis with room air saturation of 60%, referred for cardiac evaluation, view of associated significant cardiomegaly. You can see. But now this is wall-to-wall heart. That means the heart cardiomegaly is that much, it involves almost cardiothoracic ratio involved both hemithorax by 100%. So now you have to see only one thing. This is the cyanotic heart disease. Okay. This is cardiomegaly, yes. And you see there's the oligemia. There is lung are very black. So that means cardiomegaly with oligemia, 3 or 4 diagnoses like PA intact, IVS, critical PS, and Ebstein's. So it is found to cardiac size increase with oligemia. So organic this all related to organic tricuspid. Either it's a hydrospitalis birth asphyxia, Ebstein's, pulmonary atresia, intact septum causing TR, or any tumors or pericardial collection. These all are 4 or 5 conditions which cause wall-to-wall heart. And whenever this severe cardiomegaly is present, you have to think of all those things. But remember one of the things, the thymus itself will cause gross cardiomegaly in a normal heart, so you have to rule out that thing also. So this patient we found out 2D echo. You can see there is a septal leaflet is not seen, and all the both leaflets are displaced and found out to have the severe Ebstein's anomaly. So this is the displace, and this is a typical example of severe. So here there is a circular shunt happened, because what happened with severe TR, blood will go to the RA, it will go to the ASD to LA, LV, and then it will go to the outer again through the PDA with the right to left shunt, left to right shunt of PDA, it will come. So this is called a circular shunt, and that's whenever circular shunt is there, that is a more, that will cause more low cardiac output. So whenever circular shunt in exchange is a sick case, when the PA pressure decrease, almost the circular shunt also will reduce. So in that case, it will be okay. So these are the two examples where the cardiomegaly with increased flow, and the oligemia and the increased flow. Now third is the preterm duct dependent circulation. One of duct dependent I already told, either it will be increased flow situation like TG or very decreased flow like top physiology. So it's one of the twin delivered through emergency LSTS birth with a 1.T preterm 33 weeks, not cried after birth, later intubated view of respiratory distress and cyanosis. This you can see there is a cardiomegaly is there, but this is oligemia where the lungs are totally black. Again, go to your classical teaching. So cardiac size almost mild to normal to increase. So cardiac flow, but the decreased flow. So you can see there is a severe TR, and that is causing the RRB dilatation in the cardiomegaly. So once we found out it's a pulmonary atresia intact septum. So pulmonary atresia intact septum can present in both forms. If it's no severe TR, it may present as a normal cardiac size with oligemia. In presence of severe TR, it may present like in here, it may present at the increased cardiac size with oligemia. So you have to differentiate both. So here it's the atretic pulmonary wall, but no communication causing severe TR. So here in an emergency, because the prostaglandin dependent, we did the pulmonary wall perforation, now doing very fine and posted for the next stage surgery. So the other typical example of TOF, you can see the first X-ray that it shows the boot-shaped heart with PA bay conque oligemia is there. One is 40 means some vascularity seen, but it's not uniform all over. That is, and the more obvious boot shape that is typical of VSD pulmonary atresia with collateral. So these are the two examples of TOF physiology. And third is when you get the to and fro murmur, and you will find out the cardiomegaly and the mild cyanosis with some respiratory issue, that is the typical of TOF with absent pulmonary wall. So this is preterm, 2 days old, ventilated due to distress, to and fro murmur with saturation of 88%. You see there is a mediastinal shaped liver rotated heart, left lung collapse due to complete bronchial obstruction, right bronchial obstruction is happened, and that is causing a ball mechanism. So whenever to and fro murmur is there, there are only three diagnoses of ASAR, PSPR. So there are two diagnoses only for to and fro murmur. So when a to and fro murmur, you have to correlate with your, because here the to and fro murmur, desaturation and the lung obstruction is present. These are more because of the TOF absent pulmonary wall, because the TOF absent pulmonary wall, the RP, LP are huge, and that is causing compression on the bronchus. It may cause collapse or it may cause hyperinflation. Okay, so this is a typical example. And whenever you see like oligemia in the TOF physiology, and you can see some shadow like that. So that is a typical of CCTG. So with that shadow only, you can make up the diagnosis of CCTG. I told you this is a typical boot-shaped heart, but more prominent boot shape and the higher vascularity in the patches. One side oligemia, other side hypervascular. That is typical of VSD pulmonary atresia. So now we diagnose TOF physiology with CCTG, VSD, TOF, TGA, and then now there is one of the very complex that is known as heterotaxy syndrome, where there will be cyanosis, but there are complex heart disease. So how to make out on X-ray? So if you see here, the liver shadow is seen on the right side as well as on the left side. Stomach is not clear, dextrocardia, mesocardia is there, and the decreased oligemia is there. So whenever there is the situs means one-sidedness. Once that situs, situs means the situs means to see whether the arrangement is okay or not. But the heterotaxy means one-sidedness. Either right side arrangement will persist or left side arrangement is persist. So when it's a right heterotaxy, that is known as aspenia, means more right-sided arrangement. That means the spleen left side it's not be there. Lung will be like three-lobe lung both side, and the liver will be like right. Real is the right side, so it will present on right and left both side. So that is typical of the right heterotaxy. Left heterotaxy, multiple spleen will be there. Liver will be still on the left side or the normal, and then this has got the less complex anomaly. When the right side is heterotaxy, the more complex anatomy, TGA, TAPVC, single ventricle, all are very much common. So here the cardiac, again go with same cardiac size normal with oligemia, that means top physiology means decreased flow to the lung, but here the liver is midline stomach, so that means heterotaxy, that means it's a complex heart problem. In the same way, take advantage of your UVC lines and your feeding tube. First, you see there's a dextrocardia and the UVC line is on the right side, that means liver is on the right side, left side, sorry, and the heart is on the left. Then whenever there is a discordance, because liver should be on the right side and the heart should be on the left side, the liver and heart should be opposite. And when this happened, levocardia, liver should be on right side. When the liver went left side and the heart become right side, then it's a become complex anomaly. In the same way, second X-side looks normal, but some oligemia is there. But you see the feeding tube is on the right side and liver is seen on the both sides. That means there's the right heterotaxy with severe pulmonary obstruction, venous obstruction. So pulmonary flow obstruction is there. In the third way, you can see liver is on the right side, but heart is on the left side. But again, the stomach is on the right side, and the right side oligemia is there, left side is normal. So that's means it has got the complex. So take advantage of UVC, feeding tube, ET tube, liver shadow, and that with the small tools you are able to diagnose. Take help of lines and gather. The important point for situs solitus, there should situs solitus be liver on the left side, stomach on the right side, there should be levocardia. But when the situs is solitus, means liver and stomach are okay, but the dextrocardia is there. That means they are not going, heart and abdominal organ not going hand in hand. Then 98% chances of complex CH. In the same way, for situs inversus, there should be levo, and there should be dextrocardia. But when in presence of situs inversus, levocardia is there, that means 100% complex CHD. So that means simple top or simple heart disease or cyanotic disease will be ruled out. So whenever you are seeing the top, if you see the ECG will be right axis deviation like you see, and there is a sudden, you can see there is a QR wave, R wave in the V1, but there is a sudden negative transition. That is the typical of sudden change of monophasic R to the predominant negative biphasic in V2 is the typical of the top physiology. But when you will see QRS axis more than 150, clockwise loop, sudden transition V1 to V2, and then this is RVS, that is typical of VSD pulmonary atresia when the QRS axis is more than 150. Now, I already told you that there is a cardiomegaly. In top, once you see the top oligemic lung, mostly it's a right-sided chamber which is dominant. Only there are 3 conditions where the left-sided chamber is dominant. So this is 20 days old infant with history of cyanosis since birth, grade 3/6 ESM at left upper sternal border, and you can see the axis is left axis division. So any cyanosis with left axis division, there are only 3 to 4 causes: tricuspid atresia, pulmonary atresia, double inlet left ventricle, or dysplastic pulmonary one in rubella or Noonan syndrome. There are only 4 causes where, in spite of severe cyanosis, we will get the left axis or superior axis deviation. So whenever you get such ECG, cyanosis left axis, no right forces, that is only 3 diagnoses are possible. So this is one of the case, term 39, dusky, not cried immediately after birth, no spontaneous respiratory effect, deeply cyanosed, saturation 50% at 1 minute, PPB given for 1 minute, no spontaneous effort, hence intubated, back to ventilation given, connected to mechanical ventilator after shifting to this is C. Again come, cyanosis is there, cardiomegaly is there, and the severe oligemia is there. That means the lung flow is less. So TGA, TAPVC, truncus, HLH is all ruled out. Now you have to come to the top physiology. Top physiology with cardiomegaly, there are only 4 diagnoses. We told severe TR, critical PS, or PA intact IVS, Ebstein's anomaly, or when there is a cardiomyopathy which is causing severe TR, so that the blood is not going to the lung. So here cardiac size increase, oligemia. So here we suspected duct-dependent lesion, so we started PGE1 and inotrope was started. But when we saw the echo, we didn't find out any PDA. And when we see there is a severe RA-RB dilatation and blood pressure is low, you can see there is a severe RBS because of the RB diastolic dysfunction, PFO shunting right to left, nothing is going into the lung. So there is a severe RBS. So when PG is on tapered, we, because of the severe hypertrophy, they develop pericardial tamponade also with tab and sorry, and this child improved over the period of 3 years. When we asked the history of the mother told very clearly she took aspirin She took paracetamol twice, 10 days because of the high grade fever. So remember, any aspirin, any paracetamol taken in high dose or even in low dose, because you know cytochrome P450 reductase, every paracetamol, the response is different on that enzyme. So some people even with one dose of that the fetal PDA will close. All effect is on the right heart, so they will develop right heart failure like this patient. So we asked mother told she took paracetamol 2 doses, 3 doses before 10 days delivery. That's what the PDA got restricted and stopped and closed, and that is causing the stress on the right heart. And that's why even after prostaglandin your PDA not open. So these are also one of the causes where you are not able to fit, but there is a cardiomyopathy, transient cardiomyopathy due to PDA spontaneous closure due to closing, or sometimes without that also sometimes PDA get restricted in a fetus, and that is causing the right heart failure. So causes of right heart dilatation whenever come, you will see the pulmonary stenosis causing severe TR, pulmonary atresia intact septum will causing severe TR, PPHN due to any cause, infantile scimitar syndrome or any lung cause, organic tricuspid wall anomaly like Ebstein's anomaly, smaller left heart like HLHS coagulation that causes increase in the stress on the right heart, and because left side is small, your right heart will look dilated, and there is a cardiomyopathy like Ebstein, ductal stenosis in a fetal or ductal constriction in a fetus. So apart from that, we will see the extracardiac shunt. You have to rule out because there is a cardiomegaly. If you are not able to find out in that, you have to rule out vein of Galen, fetal ductal restriction, portosystemic shunt in a liver, arrhythmia or hydrops or tumors. So fetal closure of ductus artery is also common, where the maternal intake of NSAIDs or sometimes dark chocolate, green tea also will cause, SSRI also will cause. So immediate delivery, whenever you thought there is a PDA is getting restricted on fetal echo, you have to deliver very fast. So this is one of the patient, 28 days old, single ventricle PS on PG infusion. So we have to see, because we are using PG so frequently, prostaglandin, it develops swelling in lower limb. So this is very rare complication of the prostaglandin. You can see the left sided there is a periosteal elevation, while the right tibia there is no periosteal elevation. So prolonged PG infusion will cause periosteitis, periosteal elevation. That is known as the cortical hyperostosis. Once we stop the PG, in this case, it's outside somewhere in the village. They started continuing giving the prostaglandin for 28 days. But after 28 days, surgery was done. But by that time, there is a swelling in the lower limb. And after we stop prostaglandin, in the 2 days we take off the surgery, that swelling reduces. So this is a typical example of cortical hyperostosis. This is one of the patient where 6 days old with severe where the PPPV. There is a complex diagnosis where we did the stenting. So rare causes, but not very rare. Whenever the cyanosis are there, sometimes because in fetal, like what happened, the umbilical blood will come to the liver from portal and directly go to the ductus venosus, and that eustachian will direct to the PFO. Even after that, after birth, if the same mechanism persists, the IVC blood is directly through eustachian wall is going to PFO, that is also causing the cyanosis, but they are very rare. Systemic, normally IVC connected to the RA, but sometime in rare it may connected to the LA. In the same way, SPC connected to the RA, but in rare case it may connected to the LA. So that also will cause the cyanosis. Same time there will be pulmonary AVM, RPA to LA fistula, pulmonary venous atresia, okay, or absent pulmonary venopotosis. They are the rare cause of cyanosis. This you can see. This is a typical example. I show the eustachian wall, and that is directed blood towards the PFO, and that is not allowing blood to go to the RA, but it's more allowing to go to the PFO through LA. It will cause cyanosis. This is very important case. You can see this 10-year-old with cyanosis not improving with oxygen, and there is a swelling on the. If you see the X-ray, there is a bulge on the right artery. There is a very typical, one of the typical or rare cause of the RPA to LA fistula, which is one of the type of the pulmonary AVM. So this is RPA to LA fistula, and you see 1 month old, no cardiac defect, no distress, but severe cyanosis. So this is a very typical. There's a opacity, coin-like opacity on the right lung with the vessel vasculature seen, and when we did the NG, we found out there's a pulmonary AVM, and then we closed the device, and after that the cyanosis improved. So once you see like that, you have to rule out. Here there is no distress, that means lungs parenchyma is not involved, only just the, because what happened in pulmonary AVM, normally artery will go to the capillary and then go to the vein. So oxygen happened in the vein. In pulmonary AV fistula, that capillary phase will be absent. So artery, pulmonary artery which carry impure blood will directly drain into the vein. So in only there will be desaturation, but there won't be any distress. So that is the differentiating point. Okay, so this is last case, late preterm, birth weight of 2, distillation on NST, week cry after birth in view of respiratory distress soon after birth, continued CPAP, and HMB-like picture. But there is a dilated RARV, severe TR, PPHN, but we are unable to explain this. So then we found out there is a large portosystemic, there is a connection between portal vein and hepatic vein, which is causing the severe pH. We close with the coil, and after that the PPHN improved. This is one of the rare cause where the portosystemic shunt will cause. 7-month-old, just for the completion sake, in order 7-month-old right heart failure, equal air entry on both sides. That means you rule out the pneumothorax, normal breath sound, severe dysfunction. But the long oligemia on the right side. So it may be because of the bronchial compression, foreign body, the other clear. But in cardiac was one in that it may be absent pulmonary vein, absent RPA. So it found out to be the absent RPA syndrome. So the other 4 symptoms, 4 spectrum. A, you can see there is a all in the heart is shifted to the right side. A belongs to the Civitar syndrome, B belongs to the absent RPA, C belongs to the absent right pulmonary vein atresia, and 4 belong to the absent right pulmonary vein. So these are the spectrum where even the cyanosis, but you have to take clue from the X-ray and your ECM with the help of pediatric cardiologist, you can tell the cause for the cyanosis such way. If last, if it not, you are unable to get the cyanosis, do put IV injection in right or left side. If you put IV injection in right side and you put a saline, if you are able to see the filling up of the RARV and then the LA will fill, then it will go to the lung after 5 to 8 beats. This is normal. But if the LA fill within 3 beats, that means either there is a large shunt present in, but suppose there is no ASD, that means the RPA and it's suddenly coming to the LA. So once it's filling up of the LA after within 3 beats, that will suggest of pulmonary AVM, RPA to LA fistula, or sometimes severe PH or ASD causing the right to left shunt. And then saline push. And if you see filling up of the directly when we push from the systemic vein and directly LA are filling, that means the that vein is directly heading to the LA and there is a systemic venous abnormality. So that is the cause. And if you put from the lower vein and directly filling the LA, that means there is a eustachian wall directing blood towards the PFO. So that is very important. Saline push from the vein, it will confirm your catheter position also, and sometimes it will diagnose the rare causes of the cyanosis also. So cyanosis, when you present, it may be cardiac, non-cardiac, it may be peripheral, it may be central. Simple approach with you have to apply whether it's a respiratory or whether it's a blood related or it's related to cardiac. So do, once you are doing cardiac, do hyperoxia test, whether it's improving or not improving. With hyperoxia, it may improve with PPHN. No, it may improve with renal, but it may not improve PPHN in cardiac. But due to the hand ventilation was high rate, the PPHN it will improve, but the cardiac will not improve. Once you come to the cardiac, you have to see whether cardiomegaly is present or absent. No, first we have to see whether distress is there. When there is a tachypnea but no retraction, that means there is an acidotic rhythm, that means there is an oligemia with acidosis, that means there is a top physiology. When there is a distress, then either there is an incomplete admixture like TGA or there is a TAPVC, HLHS or truncus arteriosus. Once you go with the oligemia with decreased flow and severe, then you have to see there is a cardiomegaly, non-cardiomegaly. If the cardiomegaly, there are only 5 diagnoses: Ebstein, pulmonary atresia, severe PH, or cardiomyopathy, okay, and severe TR. These are the only 4 or 5 causes. And without cardiomyopathy, TOP, VSD, pulmonary atresia, CCTGA, TGA, VSD, PS, whenever there is a pulmonary flow is restricted, that is not. And these are the causes. Take clues from the pulse or X-ray, ECG. I told only left-sided forces. So diagnosis are tricuspid atresia, DILB, Noonan syndrome with severe PS, and rubella syndrome with severe PS or single ventricle. So in such case, you try to learn basic echo and take clues from your clinical examination, your X-ray, ECG, and do some echo. Otherwise, you have to tell any or take the help of pediatric cardiology and learn. And do learn basic echo and saline contrast echo. That will help in deciding your line, whether the line is correct or not. And with the help of the line, you can tell the stomach and liver is on the correct side or not, and you can diagnose the complex heart disease. And with the help of saline contrast, you can even diagnose the rare heart disease. So thanks a lot. So for your kind listening, and this is the cyanotic CAG in our syllabus for you people to see. This is the first cyanotic CHD lecture from pediatric cardiology, and next time we'll do the other ECG, X-ray findings and all. So thanks a lot for your kind listening.